So having said this, I think what would be good, Christoph, to dive a little bit into how actually imaging could help us in guiding these complex PCI cases. So why don't we just show a couple of case examples in order to give a bit of an impression on how IVUS might actually change your practice in, for instance, patients with heavy calcification.
Yes, I think it's a good point. And because if we discuss the guidelines, and they are fairly strict to say it's only for complex lesions. But for example, if you talk about calcification in some patients, you only appreciate the amount of calcification by doing IVUS. So I think it's important to have it, at least think about doing intravascular imaging in some more patients than they might seem to be complex, because sometimes you just estimate the complexity only if you really have the intravascular imaging. And so let's just start with some examples. And I think this is a patient where we see, I think, from the first angiogram already that there's a relevant disease of this RCA, and it seems that there might be a lot of calcification. But once again, to really understand this lesion and the amount of calcium and the amount of disease, the length of stent that might be needed, and so on, I think it is really important to have the information from intravascular imaging available in such a patient. And this, at the end, gives us all that we have to know to decide that this is, for example, a good case for orbital atherectomy, which we did in this patient, or to use, for example, lithotripsy in other patients, because we have now different tools available in our toolbox. So to really use those tools good in every patient and to decide what to use, we must have this informations available in our patients. So it's important to really know what is going on there. But I think for a good treatment, to decide what is the best in every case, it's really important to understand the disease, and thereby it's extremely helpful to have all the information available for intravascular imaging. So we just go maybe briefly through through the cases, and then we can discuss it. Or if you have any comments, please feel free to give your comments about this case. And this is, I think, another example of a patient with you see it with he presented at our hospital just a week ago with unstable angina. He had some elevated cardiac enzymes, and we did an angiography, and you see this ostial left main disease. And then it's always the question, of course, should we use IVUS in this case? And yes, it's important to have the information from IVUS, not only to define severity of the coronary artery disease or severity of the stenosis, but also to plan the procedure, to size your stents, maybe to upsize your stents, to think about bailout strategies, for example, to appreciate the amount of calcium and so on, and then you can have a good result. And normally, an ostial left main is a simple lesion, but it can be very complex if you undersize your stent in this situation. And it's really important to have the intravascular imaging available to see or to plan how to implant the stent perfectly. And we know from our data that at least in left main disease, IVUS is important to, it can change, the use of IVUS can change the prognosis of the patients. And we have here with IVUS the information to decide if the patient benefits prognostically from PCI or not. And in the end, and this is what I was thinking about when reading this, the guidelines, we have ambiguous lesions which might not look to be or seem to be very complicated, but where the appliance of intravascular imaging is extremely helpful to really understand what's going on. And this was another patient who presented with unstable angina after stent placement just a few months ago. And you see this, I would say, coronary angiogram it doesn't look like to be a severe stenosis, but the patient had symptoms. And then if you perform intravascular imaging, you see that a significantly under expanded stent in this LAD. So I think we should maybe define or think about defining every pre-treated patient with symptoms to be a complex patient, because without intravascular imaging, you don't really understand what's going on in a patient where is already a stent in place, and there seems to be a problem with this stent. And this is another patient presenting with symptoms, and you see this two lesions in the circumflex. And without intravascular imaging, it's not really understandable what's going on there. But by doing intravascular imaging or IRIS, we see that this patient had two problems, because in the distal part of this circumflex, there's a stent malapposition, which is significant maybe for this patient, increases the risk for target lesion failure. And what was for me in this case really what I did not expect in this case, that the proximal part of the RCX, that there was a severe stenosis with a lot of plaque formation in this patient. So one more case, which by the first look did not seem to be pretty complex, but at the end, just by using intravascular imaging, you're really able to really understand what's going on there, and then the treatment is not pretty complex. The problem with intravascular imaging is if you don't use it, you normally don't see what you have missed in your patients, and at the end you don't miss what you never see. So if you don't know it, then you don't miss it. And if your patient leaves the table untreated and you say angiographically this was not a significant stenosis, like in the case I just showed you, the patient will just come back a few months later with myocardial infarction. So from my point of view, we might just do not really estimate the total amount of complex situations if you don't apply intravascular imaging more in daily routine. And this is one more example of a patient pre-treated in this osteal RCA, and he came to us with NSTEMI 12 months later, and you see this angiogram, and there's an osteostenosis, of course, and this is are the images from intravascular imaging. And what you see here are three different problems: that this patient had a malapposition of his osteoplaced stent. Then we had this patient presented with a significant neointimal hyperplasia and a very proximal osteopart with a lot of calcification. We had a significant stent under expansion. And once again, just by looking at the angiogram, you don't really understand what's going on there. And for me, every patient with de novo angina after pre-treatment and stent placement automatically is a complex situation, because you don't really can estimate the total amount of disease just by doing an angiogram. And this is clearly an indication for IBIS to understand what's going on, and then to plan your treatment strategy in those patients.